Hi, this is Ahmet Alokaili and Manos Brilakis presenting case 258 for the Manual of CTO Interventions. This is a case that was referred for PCI of an LAD CTO. The patient was a 45-year-old woman who presented with exertional dyspnea and was found to have an LAD CTO on the coronary angiogram. There was an attempt to recanalize it that was unsuccessful, and she was referred for a repeat attempt. She was recently diagnosed at the same time with ischemic cardiomyopathy. Her ejection fraction was 25 to 30% with akinesis of the apex. She also was obese, a smoker, and a diabetic. This is the electrocardiogram, which shows Q waves in the precordial leads. And this is a coronary angiogram. No significant disease in the right coronary artery. However, the LAD is occluded in the mid-segment. There is also a high-grade lesion in the diagonal branch, but the patient has an LAD CTO with faint feeling through ipsilateral collaterals. There are also some contralateral collaterals. And these are the images from the previous attempt. The wire kept on entering into the septal branch that was located at the proximal cap. So what to do for this patient? And this is from a recent consensus document from EAPCI, showing that for patients, the key determinant about the need or not of revascularization is their baseline symptomatic status. If they have dyspnea or angina, then the next question is about their function, and if they have normal function, then revascularization is advanced. However, in our patient, there was a kinesis of the anterior wall and the apex. So the next step is to determine whether there is ischemia and viability. And if that's the case, then the patient may need revascularization. If not, then medical therapy may be all that is needed. So it was actually challenging, but we were able to get an emergent MRI. The patient came one day and was scheduled for CTO PCI on the following day. However, we performed an emergency MRI, and we saw that there was essentially a kinesis of the anterior wall and the apex, and there was delayed enhancement of the same areas showing lack of viability. Essentially, the patient had a large transmural middle AD infarct with an apical aneurysm and no residual viability. So we canceled the procedure. We referred to the advanced heart failure team, and the patient was started on spironolactone and SGLT inhibitor, and recommendation was made for ICD. So in summary, not every patient who has a CTO needs revascularization. And a key component of that is to determine their symptoms and whether their symptoms are caused by the CTO or by something else. And that something else in our case was cardiomyopathy. So this patient came with dyspnea. She had a cardiomyopathy, and the cardiac MRI was critical in deciphering the cause of the dyspnea. The dyspnea was not a sign of coronary artery disease, it was not the result of coronary disease per se, of the coronary lesions, but it was the result of the cardiomyopathy and the decreased ejection fraction. Since there was no viability, we decided to not revascularize the patient. So not every patient for CTO needs revascularization, and ischemia and viability testing can be very useful in patients with ischemic cardiomyopathy who present with dyspnea. Thank you.